Okay.
So, welcome everyone to the 9th webinar of the comprehensive neuroanatomy educational course organized by the Yemeni Neurosurgical Society in collaboration with the World Federation of Neurosurgery, Young Neurosurgery Forum, and the Pakistan Society of Neurosurgery, and Neurosurgery Coach, and the Neurosurgical TV. Today we'll have Professor Amit Taba, who will be moderator of today's sessions. Dr. Amit Taba is Professor of Neurosurgery at Kathmandu University, in Kathmandu Medical College Teaching Hospital, and he is Chairman of Neuroscience Frontline Hospital at Kathmandu, and was the Vice President of the Nepali Society of Neurosurgery. Dr. Amit, Professor, how are you?
Good to see you again. Yeah.
Yes,
And
good
thank
to
you
see
for having me here.
It's our honor that we have you, Doctor. So, Dr. Amit, you will start introducing the speakers, please.
Yeah. Thank you once again. Yeah. And welcome all of you to the Comprehensive Neuroanatomical Education Course, Module 2, which is jointly hosted by the Yemeni Neurosurgical Society with a lot of other partners internationally. We have very learned speakers today with us. We will be talking on different aspects of brain ventricle and venous drainage system of the brain. To start with, I would like to invite Dr. Baris Kucukyuruk, who is an associate professor at Istanbul University, and he will be talking on microscopic anatomy of the brain ventricles. Dr. Baris, please share your screen.
Yeah. Professor Thapa, thank you very much for the introduction. Let me go ahead and start because I don't want to take so much time. So I will be talking on the microsurgical anatomy of the ventricles. I will be staying only on the topic of the anatomy. I won't be sharing any clinical data. So when we speak about the ventricles, we need to understand actually we are going to speak on a couple of different structures. Mainly it would be lateral ventricle, third ventricle, and fourth ventricle. But we need to remember this is a three-dimensional anatomy. So the lateral ventricle has like a C shape or a horn shape structure with the frontal horn, backwards the body, and it turns around the basal ganglia and atrium and goes into the temporal lobe as the temporal horn. So it's a complex anatomy, and we're gonna review it. First, we need to speak about the lateral ventricle, but frontal horn and the body. So each of these structures have a floor on down, a roof on top, lateral walls, and medial wall. So regarding the lateral ventricle and its frontal horn and the body, the foramen of Monro separates these two structures. I mean the frontal horn and the body. And the corpus callosum, here we see, corpus callosum forms the roof of the both frontal horn and the body of the corpus callosum. On the lateral wall of the lateral ventricle, I mean again the frontal horn and the body, there is caudate nucleus. Anterior to the foramen of Monro, it's the head of caudate nucleus, but the posterior to the foramen of Monro, it is body of the caudate nucleus. On the medial wall, there is septum pellucidum. Actually, the septum pellucidum forms the majority of the medial wall, but just most inferiorly, the medial wall is formed by the fornices. And also more posteriorly, the floor of the body of the lateral ventricle is formed by the thalamus. Let's go see some anatomical specimens. This coronal cut through the ventricles, through the basal ganglia and insula is done anterior to the foramen of Monro. So what we see here is the frontal horn of the frontal ventricle. Again, the roof is formed by the corpus callosum. You see these passing fibers here. The medial wall is formed by the septum pellucidum, but just inferiorly it's actually the fornix forms the medial wall, and laterally it is the head of caudate nucleus. This is a triangular shape, so frontal horn basically doesn't have any floor, but posterior to the foramen of Monro, we will be having the thalamus. So this is an axial cut passing through the level of the insula, let me say, and we see here the lateral ventricle, mainly anterior to the foramen of Monro. There is the frontal horn, and posterior to the foramen of Monro, it is the body of the lateral ventricle. Let's see again the anatomy. The roof was formed by the corpus callosum, which is removed here. The lateral wall is formed by the caudate nucleus. In more detail, the head of caudate nucleus anterior to the foramen of Monro in the frontal horn, and posterior to the foramen of Monro by the body of the caudate nucleus is the lateral wall of the body of the lateral ventricle. So the floor of the body of the ventricle is formed by the thalamus here, basically beneath the choroid plexus here, and more medially, the floor and the medial wall connects at the fornix. So why this anatomy is important? Because there is also a venous anatomy. I will come to that, but basically, we want to see this anatomy by understanding when we go in an interhemispheric approach. Here, this is the falx, the right frontal lobe is pulled, and we go deeper, see the anterior cerebral arteries, then cut the corpus callosum, and then we go inside the lateral ventricle. Now the anatomy becomes important because we need to understand in which ventricle we are. I mean, are we in the left lateral ventricle or right lateral ventricle? We may have neuronavigation nowadays, but still it can be malfunction. Maybe after the CSF drainage, it will be showing false results. Anyways, we need to understand in which lateral ventricle, I mean left or right, we need to understand that. So when we go closer and closer, here we see the foramen of Monro. Anterior to it, we are sure it's for the frontal horn. Posterior to it, this is the body of the corpus callosum. And now are we in the left or in the right ventricle? So actually, we need to understand the venous anatomy, and our north pole, let me say, or north star, let me say, is actually on the east. There is thalamocytriate vein, a very large vein, a consistent vein, which is present in majority of the cases, humans, let me say, because the other veins, which most prominent we will be seeing in the operations, will be a vein coming anterior to posterior in the vertical axis. But actually here, we are in the right ventricle. So this is a anterior caudate vein, but sometimes it is not present. And in some specimens, let's see another one. As you see, there is a thick vein again on the vertical axis, but this time it's actually not a caudate vein, it's an anterior septal vein. So the vertical veins coming anterior to posterior by passing at the edge of the foramen of Monro can either be the caudate vein, anterior caudate vein, or an anterior septal vein. But these will be misleading. So we need to have a more consistent anatomical landmark, which will be the thalamocytriate vein. It's always there, and there is nearly never another vein on the opposite side. I mean here, you won't find any vein here coming on the mid portion of the septum. So this thalamocytriate vein coming from lateral to medial and joining the choroid plexus just posterior to the foramen of Monro will show us that we are on the right side. Let's see another specimen. You see, The thalamostrate vein collects all the blood from the caudate nucleus and other basal ganglia structures, and it drains it into the, not into the, but at the level of the roof of the third ventricle, which will be coming later. Let me go back again. As I said, we always need to find the thalamostrate vein, which will be coming from right to lateral to medial. So we understand that we are in the right ventricle. As I said, there will be no vein here. Another less consistent landmark is that this choroidal vein always goes straight in a vertical axis, but a little bit with an angle of going laterally. The pathology may depress it or push it, but it's also helpful instead, I mean, as a conjoint to the thalamostrate vein, but thalamostrate vein and this small lateral course of the choroidal vein helps us to find the in which ventricle, I mean left or right, in which ventricle we are. So let me pass these. As you see, there's another vein collecting blood both from the caudate nucleus and the septal area. So this vertical vein cannot be trusted. We always need to find this large thalamostrate vein, always on the lateral to the foramen of Monro. So let's see one more time. This is the frontal horn anterior to the foramen of Monro. The lateral wall is formed by the head of caudate nucleus. This is the body of the lateral ventricle, and the floor and the lateral wall is formed by the thalamus, the midline, the septum pellucidum, and just at the inferior level, where the medial wall and the floor of the ventricle meets with each other at the corner, we will find the fornix. So when we go around the thalamus, I mean the ventricle goes around the thalamus, first as the atrium and then into the temporal lobe as the temporal horn. As a C shape, the ventricle turns around the thalamus. So first look for the atrium. The atrium is formed, it's a pyramid shape ventricular portion. The anterior wall is basically formed by the thalamus, and we'll see the other walls right away. So this is a coronal cut passing through the atrium. The floor, there will be several prominences, one at the floor and two at the medial wall. So the floor, the prominence at the floor is called as collateral trigone, which is the impression of the collateral sulcus into the ventricle, just like the calcar avis, which is the prominence of the calcarine sulcus into the atrium. And there is a bulb of corpus callosum, which is formed by the fibers passing through the forceps major, I mean fibers passing through the splenium of the corpus callosum, namely the forceps major fibers. So this is a right hemisphere. We see the insula, and medially we see the basal ganglia. Again, this is the frontal horn, the body of the corpus callosum. Just like the choroid plexus turns, the ventricle turns around the thalamus as the body, the atrium, and then the temporal horn. Let's see this area, I mean the medial wall of the atrium, a little bit closer. As I said, the anterior wall of the atrium is formed by the thalamus entirely, and at the floor there is collateral trigone. Medially, there are two bulbs or two prominences. As I said, the inferior one is the prominence formed by the calcarine fissure into the atrium. So it is called calcar avis. And the superior one is formed by the forceps major fibers of the corpus callosum passing through the splenium. And when we go anteriorly, then we see the temporal horn. So maybe we are a little bit more used to temporal horn during the temporal lobe surgery. Basically, in many cases, we open it and go into that and find the hippocampus. So we will be speaking on this anatomy in more detail. This is the right temporal horn. The choroid plexus is removed. So we see here the hippocampus. Just above it, there is the fimbria of the fornix into the temporal horn. The roof of the temporal horn is formed by the optic radiation, and most anterior they are called as the Mayer loop. And anterior to the hippocampus, there is amygdala. The amygdala and the head of hippocampus form or are situated in the uncus. Let's go see from inferior view. As I said, this is the temporal lobe, this is the temporal pole. Mesially, there is uncus. In the uncus, in the anterior segment of the uncus, there is amygdala. We'll see it later. And in the posterior segment of the uncus, there is hippocampus. This is the parahippocampal gyrus. This is the mesencephalon between the posterior after the apex, between the posterior segment of the uncus and the mesencephalon, there is optic nerve, chiasm, and then optic tract going into the crural cistern and then ambient cistern. Let's remove the uncus and the parahippocampal gyrus as well as the fusiform gyrus to see the hippocampus into the temporal horn. When we remove the white alveolus of the hippocampus, we see these dentate gyrus or dentate gyri in the hippocampus. Then when partially we remove it, then we see the fornix here. At the anterior, there is amygdala. I'm passing these a little bit fast because the topic today is not the mesial temporal area. I just want to express that they are at the medial wall of the temporal horn, these structures. When we remove further those structures, then we see the roof of the temporal horn formed by several layers of the white matter. The most inferior ones are the stria terminalis fibers, the fibers coming from the corpus callosum. They are called as the tapetum fibers. They basically pass through the most posterior part of the body of the corpus callosum, but anterior to the splenium. Just I told before, the fibers passing through the splenium are called as the forceps major fibers, and they form a bulb at the medial wall of the atrium, the bulb of corpus callosum. But the fibers passing a little bit anterior to the splenium, and that part of the corpus callosum is called as the isthmus of the corpus callosum, and the fibers passing through the isthmus are called tapetum. They basically connect the temporal pole of one side with the tapetal fibers. These go and pass through the isthmus and go the temporal pole of the other hemisphere. And there is a gray matter here, you see. This is the amygdala, and this is the tail of the caudate nucleus. The caudate nucleus was forming the lateral wall of the frontal horn and the body of the lateral ventricle, and it turns around the thalamus and forms or courses as the tail of the caudate nucleus at the roof of the temporal horn to connect with the amygdala. So also we remove them, the tapetum fibers, the tail of the caudate nucleus. Then we see the most upper layer of the white matter fibers at the roof of the temporal horn, which are the optic radiations. So I try to go a little bit fast about the lateral ventricle because we have the third ventricle and also the fourth ventricle. There are lots to say, but I just wanted to keep it short to save time for me and other speakers. So after the lateral ventricle, there is this third ventricle. So this is the left hemisphere, including the basal ganglia, is removed. So we see here the third ventricle and the lateral wall, but I mean the right lateral wall of the third ventricle. This is the foramen of Monro. This is the lateral ventricle, and the midline is formed by the septum pellucidum. And there we see the pons. So there are several structures forming the third ventricle. Let's name them and then look back for the anatomy. So this side is the anterior side, this side is the posterior side, this is superior, and this is inferior. The optic nerve forms the optic chiasm just at the anterior margin of the third ventricle, but forms two recesses here, one above the optic chiasm and one below. The above one is named as the optic recess. The below one is called as the infundibular recess. Just we can remember the infundibulum connects here and it becomes the infundibular recess, and the optic nerve connects here and becomes the optic recess. Above the optic chiasm, there is a thin neural membrane, practically with no function. It's called as lamina terminalis, which we open in many cases in ACOM aneurysms. But superior to it, there is anterior commissure, another commissural fiber, just like the corpus callosum. The anterior commissure is a midline structure we see commonly in the sagittal MRIs, but actually it's a white matter fiber structure connecting the temporal lobes between each other. So basically, the anterior margin of the third ventricle is formed again from superior to inferior by the anterior commissure, the lamina terminalis, the optic recess, optic chiasm, and infundibular recess. The roof of the third ventricle is formed by four layers. The most upper one and the most inferior ones are called as the tela choroidea, which are arachnoid-like structures, which we see here. The mid ones, the second one and third ones, one of them is a venous structure. The other ones are an arterial structure. We'll see them in more detail, but let me name them here. The venous structures, which we see also here, is the internal cerebral veins, and the arterial structures are middle posterior choroidal arteries. The floor of the ventricle is formed after the infundibular recess. We don't see them here in detail, but there is first the tuber cinerum, and just next to just upper to the basilar artery, there will be mammillary bodies. And just after the mammillary body, there will be aqueductus, which connects the third ventricle with the fourth ventricle. At the posterior wall, there is basically the main structure here is the pineal gland. There is two recesses here, one above the pineal gland, which is the suprapineal recess, and there is an inferior recess which is called as the pineal recess. So these are the margins of the third ventricle, but let's see it in a surgical anatomy. When we want to go to the third ventricle from above, from interhemispheric approach, first we'll go to the lateral ventricle. Let's see this again. We need first to see and understand where the thalamostriate vein is. The thalamostriate vein is always lateral and posterior to the foramen of Monro. So that's why this is the right ventricle. This is the left ventricle. We can't trust the veins coming anterior to posterior, but we can have a little trust to the choroid plexus and this superior choroidal vein, which goes posteriorly, but also a little bit laterally. But again, our north pole, our main anatomical structure here is thalamostriate vein. So then there is two ways of going deeper. The first one is opening the choroidal fissure, which attaches the choroid plexus. We can open it from the forniceal side or from the thalamic side. The Professor Roton always suggested it to open from the forniceal side because the venous drainage of the thalamus can join from this angles. So if we open it from the thalamic side, we can damage those thalamic veins. So to preserve the venous structures and neural structures, he always suggested to open the choroidal fissure from the forniceal side. Also, there are these right fornix and the left fornix. We can go midline, interfornicially. But from an anatomical perspective, let's first see what forms the roof of the third ventricle. That's why we split it back, reflected the both fornices backwards. The first thing we see is the tela choroidea, and then we see the internal cerebral veins, which are the major venous structures draining the basal or deep structures of the cerebrum. So all the thalamostriate veins, caudate veins, septal veins, they all drain into the septal internal cerebral vein. And there is medial posterior choroidal arteries, which also supply the choroid plexus. When we go a little bit deeper, we see these arterial structures better. And then we see again this, as a fourth layer. The first one was tela, the vein, the artery, and the fourth layer is again this arachnoidal layer. And then we open it and go into the third ventricle. From an anatomical perspective, the choroid plexus is removed here. The choroid plexus, we are in the right ventricle. Why? Because this thalamostriate vein is posterior and lateral. So this is the right ventricle, right lateral ventricle. There is septal vein and the superior choroidal vein. We begin to open the choroidal fissure from the forniceal side. We can sometimes cut the septal vein, possibly with no major complications, to expand the foramen of Monro to connect with the choroidal fissure to expand the view. But when we open the choroidal fissure, then we can see the third ventricle. This opening can be obtained by interfornicially, but discussibly, if we go from the transchoroidal vein, there's possibility of damaging or destroying only one fornix, while the contralateral fornix will be saved. But the disadvantages, we'll see, we have a view a little bit from a lateral angle, so ipsilateral internal cerebral vein can block partially our views. while interpharyngeal approach will provide a midline and maybe a more enlarged view. But in the meantime, we may damage both fornices, which would have a big complication on the memory of the patient. Anyways, when we open it, then we see the floor of the third ventricle, the lateral walls, there is hypothalamus. We see the mammillary bodies here. Anterior to it, there is tuber cinerum, and anterior to it, there are two recesses. The inferior one was the infundibular recess, and the superior one was the optic recess. Posteriorly, there are two recesses, pineal recess and suprapineal recess. And this is a little bit closer view of the optic chiasm, optic recess, pineal recess, and this is the lamina terminalis here. Okay, I'm also finished with the third ventricle, and then at last, we go for the fourth ventricle. So regarding the fourth ventricle, I will be just speaking about the floor or at the side of the brainstem, because the roof of the ventricles, this side of the ventricle is the anatomy regarding the approaches. So I just didn't want to go into so much detail, but I can just say the fourth ventricle is connected with the third ventricle with the aqueductus, as we all know, and the fourth ventricle lies deep to the cerebellum, where in this right picture we had a cut and removed the right hemisphere of the cerebellum to have a view of the ventricle. And when we remove all the cerebellum, we have a closer view of the fourth ventricle. Here there is quadrigeminal plate, and deep to that goes the aqueductus. These are the cerebellar peduncles. And when we see a little bit into more detail, we have this quadrangular shape floor of the fourth ventricle. Again, these are the cerebellar peduncles, and just beneath them, there are lateral recesses on the both side of the fourth ventricle. From superior to inferior, there are several structures. First, I want to mention about these median sulcus along the fourth ventricle. Maybe, I'm not sure if you see it, but there is some round shape here bilaterally. This is facial colliculus, which also hosts the nucleus of the abducens nerve. They are just above an imaginary line connecting the both lateral recesses. So on the upper half of the floor of the fourth ventricle, the important structure is again the facial colliculus, and at the inferior half of the floor of the ventricles, there's first the vagal trigone here. They are not easily separable, but they are very close to each other. First, there is vagal triangle, and also the area postrema, which is this gray structure here. I also need to mention just lateral to the median sulcus, there are hypoglossal trigone. So there's hypoglossal trigone, vagal trigone, and then the area postrema. As I said, I will leave now for the roof of the, the floor of the fourth ventricle for surgical approaches. Thank you.
Thank you, Dr. Baris. A very beautiful talk, and you have so much clear in your presentation, and you beautifully covered your journey through the lateral ventricle, third ventricle, and the fourth ventricle. For the sake of time, let's take all the questions at the end. And May I ask you to please unshare your screen